Very good evening to all my dear MOS members and the ophthalmic fraternity pan-India who have joined today for this prestigious webinar. As you are well aware that out of the 21 committees, we have the MOS Academic Committee. In that, preferred clinical practice is what we are trying to pick up in various subspecialties. Today, we have a talk by none other than Padma Shri Dr. Harsh Kumar, who is going to guide us through this topic of preferred clinical practice guidelines on open angle glaucoma. And with us, we have expert panelists, Dr. Vinnie Nangia, my senior SN alumni, and Dr. Purvi Bhagat, she is the HOD at the Ahmedabad College. And we have with us the HOD of HV Desai Glaucoma Unit, Dr. Vidya Cherlekar, who is going to moderate the session. So friends, it's going to be really interesting. For all the other introduction and all, I hand over this to Dr. Vidya Cherlekar. Vidya, and everybody, a warm welcome, Dr. Harsh Kumar, Dr. Vinnie Nangia, and Dr. Purvi Bhagat. My secretary, Dr. Rajesh Joshi, also, a warm welcome to all of you. And let's start with the session. Over to you, Vidya.
Yes, sir. Thank you so much, sir. Taswala, sir. Good evening, everyone. It's wonderful that all of you have joined this webinar. So we will be starting with the introduction of our speakers. So
Slideshow.
Yes, I'm doing it, sir.
Yeah.
It's a pleasure and honor to introduce
Your voice
Dr.
is
Harsh
breaking,
Kumar.
Vidya. Your voice is breaking.
Okay. Dr. Harsh Kumar has done his MBBS and MD from the All India Institute of Medical Sciences, New Delhi, with a gold medal in both the courses and with Bodh Raj Sabharwal medal, topping 2 sequential batches of MD ophthalmology at the RP Center. He has won the Best Senior Resident Award at the RP Center, AIMS. He was formerly Additional Professor of the Glaucoma Unit at the RP Center, AIMS, and formerly President of the Glaucoma Society of India in 2010 to 12. He has over 70 publications in index journals, 3 books, and innumerable chapters in books to his credit. He has several laser procedures for glaucoma and anterior segment described for the first time in the world. He has conducted numerous courses successfully at AIOS and DOS as chief instructor, and he is a prolific teacher, taking lectures throughout the country and abroad. He performs the most complicated glaucoma procedure using the latest technology available in India, including shunts, drainage devices, and routine surgeries. He has got numerous awards and honors over the years. He was confirmed the International Medical Scholars Program Award with a fellowship at the University of Illinois at Chicago. He has won the Icon of Ethical Healthcare Award at the Health Conclave at Chandigarh. And most importantly, he was awarded the Padma Shri by the President of India in 2015. Welcome, Dr. Harsh Kumar. Very glad to have you as a speaker in our program.
Thank you.
Yeah. Now it's my pleasure to introduce Dr. Vinnie Nangia. He is our panelist today. After his basic education, RCS and FRCO, and did his clinical fellowship in glaucoma and worked as a clinical tutor at the Harvard University. He returned back to serve the Central India and committed himself to control blindness activities through proactive measures for the community towards research in public health. He established the Suraj Eye Institute in Nagpur. This institute is now recognized for post-graduation in ophthalmology and has fellowship training programs in glaucoma, cataract, and medical retina. Formerly, he was the secretary of the Glaucoma Society of India and also served as the president of the Glaucoma Society of India. He is an expert for the global burden of diseases. He has been in this role in 2013, 15, 17, and 19. He has been a collaborator with Communicable Diseases Risk Factors Consortium, Vision Loss Expert Group, and the Asian Eye Epidemiological Group. He has won several best papers in the glaucoma section at the AIOS annual conferences, and he was awarded the honorary fellowship of the AIOS for his contribution to glaucoma in 2014. He has won the P. Shivareddy International Award for Significant Contribution to Ophthalmology awarded by AIOS. He has over 150 publications in index journals to his credit. Welcome, Nangia, sir.
Thank you.
And our second panelist is Dr. Purvi Bhagat. She is an associate professor and head of the glaucoma clinic at the M&J Western Regional Institute of Ophthalmology at Ahmedabad. She has over 60 publications and 140 presentations to her credit. Her fields of interest are glaucoma, medical education, and research. She has done her international fellowship in medical education. She is a passionate teacher, and she has held various prestigious leadership positions in local, state, and national societies and committees, and also served the editorial boards of various journals, including IJO. She has won several awards along her career. She has won the Outstanding Work as a Woman in 2015, Role Model of the Year in 2016, Acoin Gold Plaque and the Silver Plaque, Leadership Award, Felicitation for Contribution to Ophthalmology, and an Inspiration Award last year. Welcome, Purvi ma'am.
Thank you.
Yeah. So now it's my pleasure to invite Dr. Harsh Kumar to deliver his lecture. Welcome, sir. And I also request the audience to post their questions in the chat box anytime during the session, during the program. We might take up questions even in between the program. Thank you. Over to you, Dr. Harsh Kumar.
Thank you, Vidya. Thank you, Maharashtra Ophthalmic Society and Dr. Jignesh for having me here. And happy Holi to all. So it was indeed little surprising to give a talk today, but well, that's it. We played Holi in the morning. And it is so wonderful to have such a lovely panel, because I know Vinay is one of the finest clinicians and I've ever seen in glaucoma. So wherever there is a lag, we can always ask him to fill in, and Purvi too is definitely not behind him. So we will go. I've actually tuned it a little more towards the practical pearl kind of a thing, but let's see whatever goes ahead. And Jignesh was wanting to publish it, so maybe Vinay can fill in the things that actually need to be published per se. So it's quite an old disease. As way back in 810, Paradise of Wisdom actually had Ali ibn Rabban giving it as a blinding disease associated with high intraocular pressure. So we think it's new, but it is not new. What is new is the definition. Because when we were in college, हमें यही पढ़ाया जाता था, any pressure more than 21 is glaucoma. But that has changed now. Open angle glaucoma is a chronic, progressive, irreversible, multifactorial optic neuropathy that is characterized by an open angle, typical optic nerve head changes, and progressive loss of peripheral vision, for which intraocular pressure actually is not in the definition, but it is just an important risk factor. So if you have a picture like this, and obviously we like to see the disc first, or take a photograph, and then we correlate that, okay, if there is a superior change over here, where the rim is not there in the disc, which means the fibers here are dead. And similarly, inferiorly, when you do a visual field, you find that there's an inferior loss, and they're both correlating. We know there's an optic neuropathy. And then whatever the pressure, it signifies that it could be glaucoma. As far as the disease burden is concerned, yes, 12 million is in India, 1.2 million blind, but this doesn't give you any idea. The basic idea for a practitioner is कि अगर 8 लोग 40 से ऊपर आपके clinic में आ रहे हैं, so at least one of those 8 people is either suffering from glaucoma or is a glaucoma suspect. So imagine, it's a huge number. When I was not able to tell people to leave, not leave, but at least concentrate on glaucoma also, and not only on cataract. This is the trick that I told them, that look at the load you have. As far as the risk factors are concerned, we know that most important being family history, age, high myopia, vascular diseases, thyroid disease, high IOP, thin cornea, cup disc ratio being high, ocular perfusion pressure, and translaminar pressure gradient. So the CSF pressure is also now coming into play into these. The question is, how are we going to proceed? The first step is it glaucoma? And that day I was giving a lecture in PGI and Shushmita told me, sir, 20 साल पहले आपने लिया था, आपने यही line बोली थी, you are more busy putting people off medications than putting them on medications. So for all general practitioners, please, your pen is mightier than the sword. एक बार आपने लिख दिया कि उसको ग्लोकोमा है, किसी के पास टाइम नहीं है. You know, you write, the patient's life is completely changed and shattered. Please be 100% careful and sure that it is glaucoma, because nobody has the time to change it. Then which type of glaucoma is it? Is it, because we know we are talking about open angle, but almost 20 to 30% may have angle closure, and now we see so many secondary glaucomas too. And whom am I treating? So please, again, for the youngsters, sit with that new patient. Sit with him, ask him who he is. The Indian people are so good, they'll tell you their entire history. Arey sir, I have got 2 daughters which are to be married. I just lost the job in COVID. I have a mother who needs so much treatment. And then you suddenly realize that if I give him expensive medication, he simply will not buy. So please be careful. You have to know whom you are treating. What is your target pressure? Which medicines you want to start with? Is our patient controlled? And the most important thing, which a lot of people, especially the youngsters, forget, the healing touch. That patient has not come to you for a scrap of paper with 2 medicines written on it. What he has come to you is your warmth and the fact. So you have to look in his eyes in the end and tell him, whatever happens, we stand by you. And I assure you that your vision with whatever you have come will remain stable. I know it may not be the truth, but you have to give him that confidence. Otherwise, his life will be shattered. And with all that AI coming in, he may go to a computer, but the difference between you and the computer is that healing touch and the warmth that a computer can never provide. So obviously the first step is to look at the disc, and nobody can say I don't have the instrumentation, because at least you have an ophthalmoscope. So look at the outer borders, find out what is the size of the neuroretinal rim. That is the single most important thing nowadays. Examine the retinal nerve fibers which constitute the rim. So if they are deficient, you know that something is going wrong over there. Look at the peripapillary atrophy, and you have to then look at the retinal and optic hemorrhage, and a lot of time you can make your diagnosis right over there. But yes, you have to then do a visual field test. And when you are looking at the disc, ISIN tool is a very good tool to follow. Almost 60 to 80% patients, the inferior rim would be the thickest, followed by superior, followed by nasal, followed by temporal. So the moment things are not falling into this picture, you know something is wrong. So even in a busy OPD, you can make out that something is not right. Let me check again. So then you do a fundus photograph, you do a visual field, and then we go on, we do an appellation pressure. And so once these things are carried on, whenever especially I go to smaller places, I go to 2-tier, 3-tier, 4-tier cities where only 10, 12 ophthalmologists are there. And then they ask me, sir, is it necessary to do an OCT? So the answer is that yes, if you have an OCT, definitely all glaucoma patients deserve that test. But if you have to refer to somebody else, then that more sophisticated examination should be done only if the fields are okay, but you suspect something is not right. So the OCT will tell you much earlier than visual fields that if something has gone wrong, or the patient is unable to do the visual fields, or you cannot follow the progression properly, and then you may have to do that. So every test has its own role, and you will have to do them at particular points of time. Explain each test to the patient, please. because you are charging money from them, and sometimes they get very agitated. People write these 5 tests, okay, go, get this done. Sit down with them. Tell them that if I don't do the visual fields, I do not know where you stand. Which medicine can I start you with? Only when I know the fields will I know that, okay, you have advanced damage, I can give you 3 medicines and things like that. And then your follow-up will depend on those tests only. And once you have explained to them carefully and slowly, then they know, yes, this test is a must. I may have to spend money on that. Then comes corneal thickness. So again, the normal corneal thickness, something around 530 to 550 microns. Thinner the cornea, more the problem, because we are under recording the pressure. The second thing is that these are the patients which are more likely to progress faster. So they have worse prognosis. Thicker the cornea, sometimes you can be more complacent, but I'll just show you a case. And thinner corneas are more common in NTG and thicker in ocular hypertension. So I had this case, 620 microns, one-eyed patient. We had been taught that time that 14 microns equal to 1 millimeter, you use this. So the pressures in a diurnal variation were 20 to 24 millimeters. The OCT was normal, the fields were normal, the disc, as you can see, and there was no wedge defect, nothing. So I was very happy. I said, okay, just come for a follow-up every 3 to 6 months. Unfortunately, the patient did not come for 1 year. And when next he came, I was shocked to see that though the fields were still normal, you can see that there was a wedge defect over here. So that was the first thing. There was a structural damage first and not the functional damage. Everything was similar. And I was really shocked. And I realized, then we went back and read. And when you do an OCT here, now you see the OCT, which is pretty much normal, has now deteriorated. So field is normal, but the OCT can give you an earlier idea about what damage is occurring. So when I went back, Parks had already said this, that prediction models like STAR do worse if correction factor is applied. So in thick corneas, do not be complacent, please, because that is what I came into. And luckily the patient came. If he hadn't come, then we could be in serious trouble later. So please be careful about corneal thickness. Do not subtract and add or something, but just get a general idea about it. Another important thing I want to share is that many times the 24-2 is normal, just like I showed you. But 30% of the ganglion cell and 60% of the cortical representation is in the central 8 degrees, where 24-2 Humphrey has only 4 spots. So upgrade your Humphrey to 24-2C program, or if you have a 10-2 in it, which will be there, you can do additional 10-2 the moment you feel something is not right. Because then you have additional 60 to 62 points in the center where you can pick up damage which 24-2 did not pick up. So that is another very, very important point. And this 2C has got actually 10 additional points in the central 8 degrees. And it is a very fast test. So I think if you have the Humphrey, you can upgrade it a little. Then comes the question that, are we taking pressures just once? And Asrani, the man who really popularized this concept, once got a delayed flight, and we talked a lot. And he was the first one to teach us that more the diurnal variation, more the variation, greater the chances that your visual field progression will progress. And again, people in smaller cities ask me, sir, हम तो नहीं कर सकते, sir, possible नहीं है. Admit कराना पड़ेगा, कहीं भेजना पड़ेगा रात का करने के लिए. तो भाई जितना कर सकते हो उतना तो कर लो, पर किसमें बहुत जरूरी है? नॉर्मल टेंशन ग्लॉकोमा, कि तुम्हारा डिस्क और फील्ड में चेंजेस है और प्रेशर नॉर्मल आ रहा है यार ऑफिस में. तो इसका मतलब पहले तो उसके जितने ले सकते हो प्रेशर लो, क्योंकि नॉर्मल टेंशन ग्लॉकोमा इज अ डायग्नोसिस ऑफ एक्सक्लूजन. That means we may have to do MRI, we may have to do detailed cardiac tests and all that. तो अगर उसमें हमने डायरेक्शनल वेरिएशन किया और एक प्रेशर आ गया भैया 23, 24, 25, तो बात खत्म हो गई. Then it becomes open angle. Again, in ocular hypertension means उसकी डिस्क नॉर्मल है, उसका फील्ड नॉर्मल है, पर प्रेशर तो यार उसका 24 आ रहा है, अब क्या करना है भाई, पर उसकी कोई फैमिली हिस्ट्री नहीं है, कुछ और नहीं है. अगेन डायगोनल वेरिएशन इसलिए करना जरूरी है कि एनी प्रेशर इफ इट गोज अबव 27 28 irrespective of other things we may have to treat. Yes, if ocular hypertension at 24 has a strong family history, there's a history of, or you see that there's a mild, very mild changes, then you may treat even at 24. But that is why in these cases a diagonal variation is a must. Again, if the patient is losing fields despite all seeming to be okay with your medicines and everything, again you have to do it, and then this becomes what we call as a diagonal control. Whether because you are going to do a visual field after a long time, 6 months, but what is happening till then? If your pressures are not controlled all the time, that means you have already lost the battle and he is going to become worse. And you all know and we all understand that once damage is already there, it is not going to return. And again, very interesting thing he taught me was doing the split diagonal variation. Don't admit the patient his whole lifestyle changes. You can just keep changing. You call one day on 9 o'clock, another day at 2 o'clock, another day at 12 o'clock, and keep doing this thing while he's in the rut of his normal life. And that kind of a split, and obviously the triggerfish contact lens would do it for us 24 hours, but it is costing 36,000. And again, it just gives you a graph, not the exact pressures, but we are going to soon have intraocular lenses with sensors where we may be able to do it. But as of now, not only an ideal mean target IOP is needed, but also a target IOP for fluctuation is a must. So we have diagnosed glaucoma, we have done all those tests. How low should we keep our pressures? So where should be our target pressure? So the ocular hypertension study says 20% lowering. The normal tension glaucoma study says 30% lowering. The EMGT said 25%, 45, and the Cigitis said 35 to 48. The advanced glaucoma study told us that average 12.3 and all pressures less than 18, then you'll have no progression. So it's a little confusing for a general practitioner, and there are a number of formulas. But the simplest thing is that if the pressures are, if the fields are mildly, very mildly damaged, and the disc is not that bad, I think you first get the pressures down below 20, maybe 18 or something like that. If, however, there is a moderate field loss, we like to keep it around 14 to 16. And if, like we have already discussed, it is an advanced damage, we would definitely like to keep it as low as possible, somewhere around 12 or even lower. So this is our initial thought. And then we follow this up and see whether the fields or the disc or the OCT is not progressing. If it is, then we need to redefine our target pressure. Before we start the medication, we must have a medicine which causes maximum pressure lowering with one minimum number of drops, because otherwise the patient is not going to put it. It has to be effective throughout 24 hours. There should be a cold chain. Cold chain should not be, the medicine should not require a cold chain. We know there are a number of sophisticated medications, they are very good. But unfortunately, in a country like ours, even if the patient maintains it, how do you know what the chemist is doing? Half the time the light is not there. So it could be a major trouble. It should blunt the diagonal variation, have minimum side effects. And theoretically, the drugs which increase the outflow are usually the better ones. And obviously, it should be preservative free, ideally, so that the ocular surface can be preserved. BAK should not be there. And obviously, if you are going to give generic drops, I do not say do not do that, because sometimes the price difference is so much that Indian people, they will not look at those branded things. But yes, you have to tell them that please check the dropper. Many times the droppers are false and too much medicine will fall suddenly. And you have to monitor these patients much, much more closely. Again, please, all women which are in that range of getting pregnant, please write on their card, stop all medications before you conceive. As soon as you conceive, please come to us so that we can monitor what is to be carried out. So what is our first line? Mostly we like to give prostaglandin analogs if the patient can afford. If he cannot afford, beta blocker still is very good drug. Then we add on dorzolamide, brinzolamide, brimonidine. And if patient is very poor, beta blockers, pilocarpine. If he can't afford anything, then definitely trabeculated. I have seen so many times people jumping up 20 to 30 pressure. 30 pressure, they'll go, oh, give Diamox de do, ye de do, 3-4 dawai de do. Arey bhai, if he is open angle glaucoma, if it is not an advanced damage, so please relax. It's a disease in decades. So just sit tight, give one medicine, check whether it is lowering the pressure by 15 to 20% means that it is effective medication. If it is less than 15%, you may have to change the class of the drug or within that class itself. If it is still not working, you have to switch the drug and then only you go ahead and add medications. But if the IOP is greater than 30 and if the discs are compromised, yes, I'll allow you to start with more than 2 medications. And if the pressure is more than 40, then no drop is going to get into the eye, and be very careful. You may have to use estazolamide, Diamox, mannitol, whatever to get the pressure lower so that the drops at least can enter. So PG analog, obviously the first thing we add to it is the timolol because it's available as a combination. But again, you wait for 2-3 weeks to see whether the pressure is getting lowered with that or not. The second line, initially I used to add brimonidine thinking that yes, it is much more effective than CIA inhibitors. But unfortunately, over the time, what I've realized is that brimonidine group does not work in the night, number one. And number two, they almost 30% patients develop allergies to that. And that will be a mess. So my second line has changed to giving dorzolamide, brinzolamide, and then going on to other things. So if IOP is not high, monotherapy before adding switch drugs. And again, 2 drugs, if you are adding, one should be reducing the inflow, the other should be increasing the outflow by either the standard method or by the uvascular outflow. And now the newer ones are available, which actually lower the epicyclic venous pressure as well. So the commonest ones are the beta blockers. The selective beta blockers are better, definitely, but they're lowering maybe slightly lower than the standard timolol. We never really ask much about them when we are asking. Maximum we'll ask is, अरे भाई कोई cardiac problem तो नहीं है, सांस तो नहीं चढ़ता, asthma तो नहीं है. But please understand, it can cause so many, and very important in young patient is the loss of libido. So please be careful that they are not depressed, they are not taking any antidepressants, and it can cause emotional lability. So be very, very careful about these small things, and please teach them punctal occlusion. I've seen very, very few people who come to me from all over the country have been taught punctal occlusion because that can really reduce the inflow of the drug. Brimonidine is a good drug by itself. The pressure lowering is quite a bit. The only problem is doesn't work in the night. And yes, be careful when you are giving it. Allergies can develop even after a long time. And many a times it can induce a lot of sleepiness. So that has to be careful. Should not be given in children at all, less than 6 or 7 years of age. And dorzolamide, brinzolamide, good drugs. Now there's more and more evidence that probably they increase the ocular blood flow at the optic nerve, and so they are neuroprotectors in some ways. They work in the night as well. DD to TID dosage. Be careful in patients who have corneal decompensation or sulfa allergies. So you have to be careful there. PG analogs are classical drugs for us. PGF2 alpha analog, alternative pathway, lowers the pressure, single drop, wonderful drug. The problem is that sometimes it can cause a lot of pigmentation, lash elongation, orbital fat atrophy. The systemic side effects are usually very, very small, so we really don't bother too much. CME can occur with that, and I've seen them a couple of times. But many a times people ask me, sir, there was this thing, is it totally contraindicated? So don't think that. Maybe in 10,000, 2 or 3 people will develop a CME. But if you withdraw the drug, immediately the CME will disappear. So just tell the patient that I'm giving this drug. If the vision drops, do come back to me. Another new molecule which was in the market now is tafluprost. Wonderful drug in itself. It has the highest affinity for FP receptors, works well. The lowering may be just on par or a little lower than the others, but the beauty that really I'm using it more is the single unit. The unims of tafluprost are doing wonders because they are completely preservative free, and patients who are allergic to so many other things suddenly find safety in this drug. The ROCK inhibitors are really rocking now. So that is the latest addition. And for all us glaucoma specialists, it's a wonderful drug. Because you can give all the drugs, and on top of that, you add this drug and it can lower the pressure further. And we know it acts in 3 ways. It reduces the inflow, increases the outflow, and it reduces the episcleral venous pressure as well. So there are 2 basic drugs, netarsudil and ripasudil. Ripasudil used BID, netarsudil used OD. The biggest problem are they are vasodilators. So they can cause a hemorrhage over there. Invariably, there'll be a redness. Please tell the patient beforehand so that they are forewarned. They can give cornea verticillata. It can give rise to microcystic edema in the cornea. The moment you stop it, it recovers. So they are a wonderful addition to us because we really use it as a 3rd line, 4th line, sometimes as a 2nd line. And some of them also have a corneal reparative process. So many a times we use it, especially in pseudophakic bullous keratopathy and things like that, where it may even help repair the cornea to some extent. And please never forget pilocarpine, time tested, increases outflow, works where nothing else does. Avoid in central opacity, cataract, operated RD, young patient, causes a lot of headache or any kind of inflammation. Astazolamide, again, people jump. Let us give 2 tablets 4 times a day, 6 times a day. Are bhai, just hold on. It's not an easy drug. So the maximum dose permitted and which will be useful will be 1 gram in a day. So 250 milligram QID is all that you should give, nothing more than that. Never forget potassium supplement. Another thing that helped me in my practice was that many patients who are on the edge of their pressures, one-eyed, very small fields left, they do not want to undergo surgery, or there's some other problem that they can't undergo surgery. Then in these cases, giving low dose astazolamide, like half tablet BD, TDS, I initially used to laugh, what the hell is this homeopathic dose? But when it actually is useful, it is so useful that it's become a part of our practice. Just do the LFT, KFT regularly, check for nausea and GIT upset. And this idea came because in anticonvulsants, astazolamide was adjunct to in Katayama's paper. I saw that he was given for 14 years. So just don't worry if you are doing everything carefully. Again, this I already told you that my 2nd line has shifted. Glycerol, again, be very, very careful because it can cause nausea, vomiting, hyperglycemia, diuresis, which many times we don't think about. It caused maximum drop in 1 hour, last 5 hours, related to increase in blood viscosity. It can drop the pressure till 20 millimeters in glaucomatous eye, 5 millimeters in normal eyes. Be careful for the safety part. Again, mannitol, be careful, the heart is not compromised because I've seen enough patients go into CHF. So, and especially give it only if you are alone in practice, don't go, send it to some hospital to give it. 60 to 100 drops per minute, 1 to 1.4, usually 200 to 300 cc for an adult. Classically 1 to 1.5 gram per kilogram of a 20% solution, that is 20 grams per 100 ml. Again, be very careful, there could be disorientation and cardiac problems. Again, we do know that the quality of life is primarily dependent on the surface of our cornea, because all the works now, especially computer work, has become so important. And we do know that all multiple medications will cause a dry eye syndrome. And that is why the potential benefit of fixed combination. So what is it giving us? Additive efficacy, less of preservative exposure. Medication washout is not there. And the biggest thing is, not only the cost is less, the adherence is more. So there are a number of them, and we have now brinzolamide brimonidine combinations also. So we are very lucky to have so many combinations. The disadvantage is if you start it off suddenly, the problem will be that you do not know if an allergy develops to which area it has, to which drug it has developed. Again, if you need to blunt two peaks, then you may have to separate out the two drugs. If you have done everything and the cause is not clear why your patient is still worsening, which happens so many times to each of us. Once you have checked that yes, he is taking the drug regularly, please do a 24-hour BP recording around with Holter, because many a times the diastolic BP may be getting lower too much. If it is less than 70 millimeters, the perfusion pressure may drop below 55. No blood is reaching the eye, and the damage will keep happening over there. Again, if you are doing a Holter monitor and there are arrhythmias at any particular time and the blood is not reaching eye, the same thing will happen. Please check, because of the latest fad, so many people drink 4 liters of water in the morning. They are doing Shishasana or asanas in which you have to hold your breath and the head is down. All these things will worsen glaucomas. Sleep apnea. The simplest thing to ask is he snoring a lot? If he is snoring a lot, sleep apnea may be there. Check, send for the study, and CPAP can really help the patient. Again, check the profession. Is he a singer? Is he talking very, very loudly all the time? Is he blowing instruments? All these things can add on to things which we are not looking at. But if things are not falling into place, please look at all these things. Another very small thing, but when we are dealing with one-eyed patients with very little vision left, we have to really look at everything. So I tell them, please lie on the side of the bad eye. The only one eye is left. If the good eye is on the higher side, it is more protected. So these are small, small things, but they do help and go in a long way. Please explain to the patient what is glaucoma. So many patients who come to me, they have no idea. They have been given pamphlets, they don't read it. Please tell them, come to me 2 to 3 months for pressure recording. Come to me 6 months to 9 months or a year for field recording. Whenever you feel abnormal, please do come to me. Please teach them punctal occlusion. And most important, please tell them that they will be all right if they are with you. Thank you very much for your kindness.
Thanks a lot, sir. Very well covered. Almost a book that I have expected. You have covered almost everything. And I feel all the people who have joined are really going to benefit, because the basics and what are the treatment modalities and how to go about it, the protocol to be followed has been very well covered. Now let's start the panel discussion, Dr. Vidya, and we have our expert panelists with us. So over to you, Vidya. Any questions you can ask. Thanks a lot.
Thank you, Dr. Harsh Kumar. Yeah, thanks a lot, Dr. Harsh Kumar, sir. You covered this vast subject of primary open angle glaucoma in such a short time, such, beautifully covered all the aspects, the diagnosis, the test to be done, medical,
the practical tips also very nice.
words and the healing touch. That is very much needed for managing these patients. Thank you very much, sir. So, Dr. Nangia, sir, would you like to say something before we start the discussion?
Is there anyone who wants to ask questions? Actually, I'm not able to see any questions
even I
in the
was
chat
looking.
box. So okay.
There are no questions.
Anyone wanted to ask a question, please ask to Vinay, because my throat is really gone.
We are not going to spare you, Harsh.
Continuously so nice, sir. And with all the practical tips, we are happy.
So,
Yeah, Vidya.
Thank you very much, Dr. Harsh. And, with years of experience, I think you get to hear a talk like this. And there were many, many interesting aspects. And I'll just like to touch on a few and take all your opinion also about it. That case that you mentioned about the patient who came with an intraocular pressure of 24 and had a very high CCT of 620 microns. I thought that was very exciting that he developed, at what one might consider, falsely high intraocular pressures and therefore normal intraocular pressures. Really, he developed on follow-up the retinal nerve fiber layer defect. So this is unusual, and we may consider it to be a normal pressure glaucoma developing in presence of a very high central corneal thickness. So that's what I was thinking about the patient, because even in India, there would be maybe about 40 to 50% of our glaucoma patients that don't present with elevated intraocular pressure. So I think that was the thing. And the other thing I wanted to, you touched upon the fields, peripheral and central fields, and I'd just like to take an opinion also of all of you here on the panel. Do all of you recommend that in all patients we should do the 30-degree or the 24-degree fields as well as the 10-degree fields, the central fields? Harsh, Vidya, and
so Vinay, if you feel that if you are lucky enough to do OCT and the GCC is abnormal, then one would be then one has to do it. Or if you feel that things are not falling into place and there is some changes in the disc and all, but they are not reflecting the field, then only you do the 10-2, because then it becomes a lot of additional time. And that is why the 24-2C is really exciting, because it is so much faster and it is giving us much more knowledge.
Okay. Does Vidya have anything to say? And
yes,
Dr.
sir. Usually, earlier we were used to do this 10-2 fields for a little advanced glaucomas, where we have to closely monitor the central field. But of late, as Harsh sir said, even in early glaucomas, when the 24-2 is normal, but the disc shows some changes, and we would like to look for some changes, a 10-2 can help us.
Okay.
Dr. Purvi,
yeah, same with me. Not in all the cases, only in select cases, as mentioned, when the structural changes are evident, but the routine 24-2 or 30-2 are coming up normal, then probably, and there is a strong suspicion that something is actually happening, then only we subject to the 10-2.
Okay.
What is it? Abnormal GCC? Can you explain for the general ophthalmologist? Sir had said, no, there is an abnormal GCC, you do 10-2. 10-2.
Okay, when the OCT, in the OCT, the ganglion cell complex is showing abnormality. Okay, so the nerve fiber layer may be normal, but the ganglion cell complex may be showing some abnormality, which could also occur because of some macular changes. But the OCT will usually tell you whether there are some macular changes or not. In that situation, you would really like to go for that. Okay. So Vinay, I would like to ask you any idea about this OCTA, because is it helpful in these very early cases, or what is happening there?
Actually, although we have it, but I'm still not sufficiently experienced to give a personal opinion about its usage, because in many patients you get a lot of artifacts actually, and so it's very, very hard to really depend. So you really need to select only that small number of OCTAs that are fully reliable, that don't have an artifact, that are high resolution, and then you need to compare it with whatever visual fields or ganglion cells. So we haven't reached that stage as yet. We're still working with it actually.
And if I may add, I think even I don't have that experience of the Octa, but overall the general opinion is, since it detects the compromise in the circulation, it's still very unclear. whether it's the compromised circulation that is leading to glaucoma, or it is the glaucoma that has led to the compromised circulation, because ultimately it's a vicious cycle. So I think that aspect in Octa is still not very clear.
Yes. Vidya, would you like to say something?
Yeah. So the case you showed, the one with raised thick cornea, but the other features were normal. So should we also take it like a perimetric glaucoma, where the disc was not in this case, but if the disc shows some changes but the visual fields are normal, this is the pre-perimetric glaucoma or a disc
So Vidya,
suspect.
very
Then
nice.
how do we go about
I think
managing this
very,
patient?
very nicely asked, because truly speaking, when the disc is not showing anything, the OCT is also not showing anything great. So I think the only thing is you have to be alert. What I was trying to put forward was that thick cornea should not make you complacent कि नहीं भाई सब ठीक है आप जाओ घर अब आने की जरूरत नहीं. So we have to be careful on that. That is the only thing, because previously we were taught quite differently. So I just want to drill that point in, that don't let that one patient, there may be more than that. It's just a follow-up. I don't think theoretically, Vinay, what would you say if everything was normal in that case? What would you have done?
I mean, you do tend to want to follow up these patients. The only thing was that I thought that your patient really didn't give any signal that, something like this is going to happen actually. So I think that was a real surprise. But I think that, and also that, when you get 620 millimeters as the CCT, then the pressure difference, the pressure is falsely high very significantly, not just marginally, but very significantly actually.
Right.
So this is a very unusual case that you have showed to us, and of course you're emphasizing, and that's important, that with the slightest hint, don't let the patient run away, just keep the patient on follow-up.
Follow-up is very important in these patients, as well as patient education, because many of our patients don't turn up. Once we say ki everything is at present normal and we tell them to come for follow-up, but due to some reasons, follow-ups are missed by these patients. So it's important to educate the patient also, I think, sir.
I wanted to go back to Dr. Harsh. We've always struggled with the target pressures, and I think Dr. Harsh told us that if you can just recap on what you suggested about the target pressures, that when do you aim for the low teens and things like that. Harsh?
Okay, so for a general practitioner, if you're sitting in your clinic and you find a disc which is okay, you have done a visual fields, and the fields are only mildly damaged. Mild means less than 6 decibel changes. So one would possibly get the pressures down below 20, maybe something between 16 to 18, and have a look. So first do your diurnal control of the pressures to make sure that all the pressures are within the range. And then you can repeat the visual field and find out if the fields are stable. If they are stable, the pressure you have chosen is okay. If, however, there is a moderate damage, or if the patient is one-eyed, possibly you like to put the pressure somewhere around 14 to 16. This is just the target pressure you are setting. It is nothing. You don't even tell the patient. Never tell the patient the target is so much. Otherwise, you will phone calls. अरे सर आपने वो 14 बोला था वो तो हो गया 15 हो गया. So it is just a range, and we are just looking at general things. And yes, if it is an advanced glaucoma, then we are not going to leave any stone unturned, and then we have to keep it as low as possible, which is theoretically possible. Means the patient can afford those medications, he can put those medications reliably. You can go below 12 if it is possible, definitely. And if you find at any point of time that he is not going to put those medicine, I will prefer at least one eye you tend to operate.
Anmol, sorry to interrupt. Anmol, the technical person, can you just check the Facebook and the YouTube link and the webcast? Any questions? Please post it on the personal WhatsApp of Dr. Vidya, so she can ask questions. In the meantime, sir, as representing a general ophthalmologist, I would like to ask the question to all the panelists here. A person has got an applanation tonometer, he's got a direct ophthalmoscope and a 90D lens and a gonioscope. And the person walks in with a pressure on the applanation as around between 20 to 22 or 3-4 visits. How does he go about it in the periphery, most of the remotest place in Maharashtra? How does he manage such a case? Would like to have opinion of each of you.
Harsh?
Purvi first. I have spoken a lot.
Okay, Purvi. There you are, Purvi, you're going to say something.
In
Yeah,
a metro
actually, that's
city
the
or a mini metro, this can be because you have the fields to be done, OC to be done. But a person who is in the most remotest places and the nearest is around 300 kilometers away from that place, the tertiary center, and he has got these things. How does he go about it?
Yeah, I think that's the best things actually in the armamentarium that anybody could have. If you have a good slit lamp, a good enough gonio lens, and a 78 or 90D, that is actually more than adequate what you need. So a good clinical examination, a good slit lamp evaluation, a good history taking itself will tell you at least about say 75 to 90% of your diagnosis. So once then you're sure that the patient has glaucoma or probably even has the risk of developing glaucoma, is a glaucoma suspect, then you can counsel the patient, explain to them the need for further evaluation, maybe a perimetry if needed and imaging, and then refer them accordingly. So a good clinical examination and a good slit lamp evaluation and a good history taking, a thorough history taking will tell you a lot.
What criteria on a clinical evaluation will you send it for further evaluation? And when? How fast it should be done?
A clinical evaluation, how fast, like as much as possible on the first go itself, the moment the patient presents to you, and irrespective of what they are complaining, it could be just a dimness of vision, they might just have come for correction and glasses, or maybe just to have some lubricating drops, or maybe for a cataract evaluation also. But irrespective of what the original complaints are, you need to do a thorough evaluation, and as I said, a good slit lamp evaluation. And anything which looks doubtful, then you should, it should motivate you to do a further complete examination. So as much as possible on the first go, in the first counseling session itself. Gonioscopy is of course a must. It goes without saying that you need to do a gonioscopy, because as Harsh Kumar sir said, the second question, which type of glaucoma it is. So you cannot manage glaucoma without knowing which type of glaucoma it is. So as soon as you take the tension, whatever tonometer you have at hand, then do a gonioscopy and a central or a dilated fundus evaluation. Because if you find on gonioscopy the angles are open, you can right away dilate the patient. If you find the angles are occludable, then again counsel the patient, tell them the need for a prophylactic PI or a therapeutic peripheral iridotomy, and then you can dilate the patient and do a good disc evaluation.
Perfect. Other panelists, please, one by one, your opinions. It's a primary question for all the general ophthalmologists in the remotest part. They don't have the OCT, they don't have the Humphreys perimeter. What you said, they have a gonioscope, they have a applanation, a 90D lens also for evaluation. How do we go further? Vinay, first you.
So I think that, let's assume that this patient has got open angles. And the most important thing here with pressures of 20, 21, 22 would be for him to take a look through the dilated pupil using the 90 or 70 adapt lens actually. And based on the optic disc evaluation, he may decide whether to keep the patient on follow-up, especially if he's not convinced that there are any changes in the retinal nerve fibula and optic disc clinically. But if there are changes, then he may start the patient on drops, and at the same time refer the patient also to for further evaluation with perimetry, OCT, etc.
Yes, Vidya, you are seeing a lot of patients from the periphery of Maharashtra coming to HV Desai.
Yes, sir. As
So you must be getting a lot of referrals from the general ophthalmologist with such pressures.
Yes, definitely. For lack of instruments or lack of equipment in the periphery, definitely history, slit lamp examination, and a careful disc evaluation, sir. I would give more importance to disc evaluation, clinical evaluation. Applanation tonometry can have some errors. Some people may not have an applanation tonometry. Many people still rely on Shiots and NCT. But disc evaluation is very important. And that will definitely guide us or give us some opinion, give us some indication that
So
Voice
I
is
was,
cracking.
yeah,
Vijay, your voice is gone.
voice is cracking.
Voice.
Cracking a little.
Okay, so
Anyway,
we can
हर्ष साहब आप बोलिए,
follow
उनका आवाज नहीं
नहीं,
these
गया.
वो
patients
he had
and
to
treat
stop
the
only then
patients
I can
also.
speak.
Yeah, Vijay, I think you can stop your voice is cracking for a moment. Once you get back
Anyway,
the
one
net.
interesting thing I want to share. I was giving a lecture in very small town, and one
Yeah.
ophthalmologist at then stood up and said, "Sir, आप मुझे ये बताओ, I have just enough money. Should I buy an applanation or should I buy a computer for my child?" दिनेश जी, क्या आंसर है आपका?
सर ये पर हकीकत है अभी भी in the remotest
वही,
part what they
सर
have.
ये जो हम applanation बोल रहे हैं ना, मुझसे मत पूछो.
हाँ,
I will not name the states. I will not name anybody.
correct.
But you will be shocked at the number. Few people who have applanation also, it is there as a as a trophy. It has hardly ever been used.
यूज नहीं होता है.
So let them
Can I
use,
add? Yeah.
let them use what they can use, and so we should not tell them no, not this. What you have, use correctly and with whatever parameters we have been taught that इसमें ये गलती हो सकती है, ये गलती हो सकती है. And please take the history carefully. If you have a strong family history, then that 22 becomes a serious matter. So, and again, family history में हाँ था तो glaucoma, अब पक्का नहीं है. But if they have lost the eyesight, and then tell them next time भाई पेपर लेके आना अपने, तो मैं तो उसके पेपर मंगाता हूँ, then you immediately understand कि भाई क्या status है उसका. That tells you the gravity of the situation.
Sir, here also you
something
prefer to say a diurnal variation should be done because we don't have other instrumentation before it sends for further evaluation.
नहीं सर, नहीं वो नहीं हो पाएगा ना.
आया उसका 18-20 आ रहा है.
It is not possible. So at least जो दिन में जितना तुम्हारा ऑफिस है, जब इन द मॉर्निंग तुम जाके बैठते हो, जब तुम लेटेस्ट रात में निकलते हो, तो उसके बीच में आप जितने कर सकते हो कर लो. और उसके बाद जैसे मैंने बताया कि या तो नॉर्मल टेंशन ग्लॉकोमा है या ऑक्युलर हाइपरटेंशन है, या डिस्पाइट ऑल ऑफ योर डूइंग द फील्ड्स आर स्टिल ड्रॉपिंग, इन केसेस में आपको भेजना पड़ेगा भाई डायर्नल रात का भी कराओ, along with the other things that we said about 24-hour BP recording and all that.
Can I add
Yes,
something
Vidya.
here?
Yeah,
हाँ,
Puri,
बोलो.
go ahead.
Yes,
बोलो.
Yeah, talking of all these remote places and patients going to a general ophthalmologist, actually it is also important to be aware of the other end of the spectrum. Like patient actually may not be having glaucoma, but just an isolated reading, especially on an NCT, and they are all tempted to start away glaucoma medications, so that is also not something which is preferable, because for the patient, it's a lifetime a disease and a drug they are going to use. So as then it's a different cycle altogether. Then the patient ultimately, when they reach a glaucoma practitioner, it's a different task altogether to again reevaluate, set a new baseline, wean them off the drug, and start all over again. So not to be too enthusiastic to right away start treatment also.
That is why I asked this, how many readings we are supposed to take? Do we do diurnal or do we take 3-4 readings before we start any anti-glaucoma?
नहीं 3-4 तो कर ही लो सर, 3-4 रीडिंग तो कर लो. But you have to look at the dilate. जैसे विनय ने कहा, डायलेट करके डिस्क देखना तो बहुत जरूरी है भाई, उसके बिना तो आगे नहीं बढ़ सकते. और वो इतने बढ़िया डायग्राम दिए हुए हैं, सब कुछ दिया हुआ है, तो उसमें गड़बड़ करना जरा मुश्किल है.
So the preferred first line drug for everybody is a beta blocker, or we go for this prostaglandin analog.
If the patient can afford, it is PG analog. If he cannot afford, it's a beta blocker.
And I would also add something that the patient can tolerate actually. That's probably very critical. So sometimes we're able to afford, but we're not able to tolerate a particular drop actually.
And if there are contraindications, because
and pressure lowering. and pressure lowering.
Efficacy.
Efficacy.
How is the fastest follow-up for such patients? The initial glaucoma workup ho gaya, and then we have started a drug. How frequently a person should be called initially to titrate the?
जब पहली बार दवाई शुरू की है तो आप 3 हफ्ता तो देंगे उसको दवाई का असर आने में. So you will call them after 3 to 4 weeks and check कि pressure adequately lower हुआ है कि नहीं. And फिर उसके हिसाब से देखेंगे अगर वो हो गया है, टारगेट प्रेशर आपका बन गया है, तो आप चाहो तो 2-3 बार बुला के at different point of times make sure that हाँ भाई at all point of times my target pressure is being reached. क्योंकि फील्ड तो आप करने वाले हो 6 महीने बाद, उससे पहले मरीज आएगा नहीं फील्ड करवाने, कहेगा यार ये डॉक्टर तो बार बार पैसा लेता रहता है.
That was my next question. How frequently do you do field? So you have answered that too. Boliye. Yes,
what is the, yeah, one question to all the panelists. What is your take on the generic versus branded medications?
Yes.
Because considering our population, economy and the cost of buying drugs is definitely a problem for our patients. So what about?
So with that, I already covered that, and I said that
yes.
Sometimes उस दिन मेरे को इतना शॉक लगा, the difference was 4 times.
Oh my God.
The cost. तो पर you have to tell him कि भाई दिखा कौन सी दवाई डालना है, and check the bottle. Sometimes वो पिचकारी की तरह से सारी दवाई उसमें से एक ही बार में निकल आती है. So then you don't want that kind of nonsense. So if the drop is okay, if things are okay, then let him continue that, but just monitor more closely that भाई pressure उससे down हो रहा है कि नहीं हो रहा है. So I think we cannot just outright, not in our country by any means can we say कि नहीं use करना है. Vinay?
So I want to tell you that we studied the costs involved in using medicines, and we compared medicines that were made by overseas companies and available here compared to and compared them to Indian companies within the country. And we got a shock actually that using the medicines made by overseas companies turned out to be cheaper than the medicines used by Indian companies, because one of the reasons is what Harsh pointed out, that you get less drops actually. If you get less drops, then there's a lot more wastage, and the cost was not so different between the Indian and the overseas companies. So I think it's very important for all of us to do this study for ourselves, count the number of drops and calculate the cost per drop actually. And that's one way of looking at it. And if the cost difference is just very marginal, then maybe it's better that you opt for the original molecule actually. In some instances, what we have done is that we have fallen back on the Jan Aushadhi, shops actually. They're only just now beginning to increase in number, but the same medicine made by an Indian manufacturer available in a private pharmacy, the costing will be much higher than when they make it available through the Jan Aushadhi shops actually. So I think that is something that we may use when we really need to reach out to the patient and we know that the medicines are not very affordable to them.
One more question is regarding the fixed drug combination, keeping the compliance in mind and people coming from way out, almost 2-hour journey, 3-hour journey. Do we start with fixed dose combination? Sir has partly covered it. What is your take, Vinay, Dr. Purvi and Dr. Vidya? Sir has already covered, I think, part of it. Fixed dose combination for open angle glaucoma.
So, I do use fixed dose combinations very, very frequently. And my favorite is alpha agonist and beta blocker actually. And I think that there are advantages because there's nothing to say that you shouldn't use them. There's nothing to say that the efficacy of a fixed dose is less than when you give 2 drops separately. And I know personally from experience what it is like using 2 drops instead of 1 drop actually. So I think that I would generally support where indicated that a fixed dose combination may be used actually.
Okay. What about the rest?
Even I use a lot of fixed drug combinations, but the only thing is which patients need these. Very early glaucomas, maybe we go in only for a single drop, but moderate to severe glaucomas, when we need more than 1 or 2 medications, fixed drug combinations definitely improve the compliance and also the safety profile. the side effects are reduced, patient's tolerance is better. So definitely they are preferred.
Yeah, Purvi.
Yeah, for me, actually, unless the IOP is significantly high and it's a case of advanced damage, like anything more than say 28, 30s, or patient is a very high risk of losing vision, then I start with 2 medications, but not a right away FDC. Only if I find that the patient is now controlled and both the drugs are acting and the patient is tolerating the drugs, then I switch over to a fixed dose combination. Not an FDC at the first go.
Okay.
Of course, we are discussing a lot on the medical management, but I just wanted to also discuss 1 or 2 questions about the surgical management also.
Yes.
Dr. Harsh Kumar sir, trabeculectomy is the gold standard surgery, but of late all new MIGS surgeries, goniotomy, trabectome, Jagat, all these are talked about. So what is your take on these new surgeries? Which patients do you perform these?
So let us go to one by one. Trabectome is very expensive machine, and it is pretty much only those people who have those are in big institutions can use it. So that is out of question. I've seen a lot of people try just a needle to do a goniotomy and open up the angle. But frankly speaking, and a lot of my friends are very, very skeptical because that in adults, it invariably closes up. I have started doing the MIGS, eye stent. So it actually takes a lot of practice because it's under very high magnification. You have to have a good microscope. So we have just done a few, and usually you have to add it on to the cataract. The unfortunate thing for all the MIGS as of now is the costing. So the moment the costing comes down, it'll be, and I can tell you, all of us will have to look into the angle sooner or later, because there are multiple devices which are coming up. So the eye stand chap, I thanked him so much profusely. I said, now I can put anything in the angle with your teaching me again, the putting how to put a gonioscope and all that. So Zen gel is coming, so many other newer things, but you have to all go through the angle. So sooner or later, all of us will have to learn the angle surgery, because we all know how difficult trab is, how unpredictable trab is, how much nonsense we create for the patient with so much of sutures, this, that, elevated bleb going into this, that. All of us know that. So we will be so happy to get rid of trab, but I can tell you, as of now, there's no riddance.
And about the SLT, sir, what is your opinion? Nangia sir, Purvi ma'am.
I've not done selective laser traffic.
Yeah, actually, I was going to bring that on now, that topic into discussion, that it's an intermediate, a good intermediate between medicines and surgery, and it works very well. We have SLT. I've been doing it regularly since about 3 years now, and it works quite well in a lot of patients. So significant amount do need repetition, but it's actually so benign that and the patients are very happy just to be put off the drugs for that interim period.
Somehow or the other, Purvi, North India, it is not caught up. And I can tell you, I always quote my teacher, Dr. J.C. Das, who has done thousands. And he was thrown out of the SLT group because he actually always criticized the fact that it just does not work. Mm-hmm. I have yet to see one patient, because any patient who comes to me from abroad, and there are thousands who coming back from US, London, this, that, all of them have had an SLT, and none of them are controlled. Mm-hmm. So yes, there are a couple of, I don't know, there are some localized, isolated places where people are very fond of it. But the hard fact is that if it was that good, and I have done 2 or 3 cases, but frankly speaking, I was not impressed. So
Actually, it just helps in a kind of a transient and temporary measure. It gives you more time and helps you to delay the surgery.
if you are sitting in a government hospital, it is good. But if you are sitting in a place like my place, where most of the patients are elite, they are wanting results, and they are paying, so they are always, and at least we were not able to earn good pressures in more than 60%. So 40% is a huge chunk. So anyway, so anybody who has a machine can try. Definitely, there is the biggest, like Purvi said, is no harm trying. So if you have a availability of machine, go ahead. Please go do.
Do you use it as a stopgap arrangement between trabeculectomy and the drug, sir? Or is it a regular procedure?
Not at all. It is only for the primary glaucoma where the patient does not want a drug, and then you can put it. If he's already on 2-3 drugs, then it is a very temporary phenomenon.
Okay. Sir, one more question which I would like to ask everybody, in fact, is a one-eyed patient who is coming with borderline pressures, as I said, between 20 and 24, with all investigations done, how closely you follow up a one-eyed patient vis-a-vis both eyes seeing with one-eye glaucoma? What is the change of management and how do you go about it?
Vinay, sir.
Vinay, you start. I think then Dr. Harsh will speak last because I think he has spoken quite a bit.
Every time you have a one-eyed patient, there is increased concern for the patient. I'm not sure that that the management strategy would specifically change just because he has this is his only eye. It would only be at the time of doing surgery, and let's say that he had only a very small central field of vision left. That is where there would be a discussion with the patient as to what might be done, but it would not change the management ultimately.
What about the frequency of visit? Do you call him very often, a one-eyed patient, to follow
would
it up,
not,
or
actually.
it's the same protocol which you do for the others?
Yeah, I would just call the patient just as there was someone else with glaucoma in both eyes, or there was someone else with severe glaucoma in one eye and moderate glaucoma in the other eye. So my follow-up or my management would not change because he was one-eyed. There would be greater concern for the patient, greater empathy. That human touch would be a little bit more. Maybe I would spend a little bit more time explaining to him, ensuring that he's using the drops, speaking to the relatives. Those are the kind of things that might be done a little bit more for this patient, actually.
Yeah, Purvi, your take, and Vidya then.
Yeah, one thing is if the patient is one-eyed, I would like to see what is the reason for the loss of vision in the other eye. Is it actually glaucoma or it is a non-glaucomatous cause? Because if the patient has lost vision in the other eye because of glaucoma, it is of still further significant concern to me, because I need to be more aggressive in my management and perhaps monitor more closely. And regarding the frequency of the observation, as Sir has very rightly said, actually it all depends on how well controlled and stable the patient is, and then as for any other case.
Vidya?
Yes, same like what Mad said. Definitely look at the other eye, whether it has been lost because of glaucoma or some other disease. That is most important to decide the follow-up and management of the seeing eye. Based on the severity of glaucoma or whatever disease, depending on the severity, I call for follow-up.
So perfectly, they've said absolutely right. The only thing I want to add is all one-eyed patients, please teach them to look with a slight tilt in the head, because they are much more likely to get into accidents. And these small things, many a time we are not doing. Especially if the other eye is defective, tell them to put a squirrel shell over there to look like a normal human being. These are small things which add on so much to that patient's life.
One more question is regarding follow-up. As we require, it's a lifelong disease and the treatment has to be given. In follow-up of keeping the monetary aspect and the frequency with which we call, which is the priority test which should be done on follow-up cases? With monetary, as you said, paisa banate, bhai, feeds kar lo, OCT kar lo. So what exactly is needed on a follow-up this thing?
सर करना तो हाँ पूर्वी go ahead.
नहीं सर बोलिए सर.
नहीं मैं तो वही कहता था भाई.
नहीं, everybody has to speak one by one.
हाँ, everybody has to. Sir, field तो करना ही पड़ेगा. There is no choice because that is the only way we are going to run the progression. So if and please, what we do is for the practitioners, I'll tell you, whatever you charge, please keep a charge in that. That if many a times the patient is tired, he has come from a far distance, so he may not be able to do the field properly. So let him relax. If you have to repeat the fields with dilatation, sometimes to bypass the cataract, you may have to do it within the same charge. But the field is the test that we have to ensure that it has been done with same regularity and it has been done correctly, so that the false positive, false negative, and all those fixation losses are not there, and we can then make a decision whether he is worsening or he is stable.
Yeah, Purvi.
Yeah, same like sir. It's a perimetry and repeat disc evaluation, and of course IOP. Those are the investigations. Perimetry and disc evaluation must along with the IOP.
But that should be done once in 6 months or a little more frequent.
Yeah, actually, it depends on what stage the glaucoma is and how stable the patient has been over that period. So it could be 6 months in the initial few years. If you find the patient is compliant, stable, and the status is maintained, then it could be yearly also. The perimetry could then be yearly.
Yes, anything different, Vidya and Vinay? Otherwise, I'll ask the next question.
No, the only thing is that, we're beginning to rely more and more on the retinal nerve fibula and the ganglion cell maps, actually. And that's because, the perimeter has stood the test of time, except that in some instances, somehow you get this feeling that things are not matching actually with the optic disc. So for that reason, we would also like to do the retinal nerve fibula and the ganglion cell maps to enable us to follow up our patients better.
Yeah, Vidya, anything different?
Yes, sir, definitely perimetry would be the first investigation. And depending on the, the severity of the disease, it would be once in a year, or in more severe cases, once in 6 months, and even 3 months if it's a very advanced glaucoma. And definitely, as we have the OCT also, sometimes we do OCT if the patient really, needs it. Of course, financial issues are there, but
Yes.
if it is available and then the patient requires that test, as just now sir was saying, we do that also. But disc and field examination and its correlation, I depend on that, sir.
Correct. Now, the most important question is glaucoma with cataract. Open angle glaucoma, uncontrolled medically. And you have cataract, a one-eyed patient, and with one-eye glaucoma, one-eye cataract. How do you manage? Surgery, combined surgery, standalone glaucoma first, then cataract, or what do you do? Each one of you can please answer. I think that will be the last question we'll take now, because there are many more, but then it will go on and on.
There is one question from the audience, which I think we should take after this.
Yeah, take please, Vidya.
Yeah, after this, yes. Dr. Harsh sir or Vinay sir, they can answer this.
Okay.
And then.
So my take is that I have shifted, initially as a glaucoma surgeon, anything with a little bit of moderate glaucoma, I would go ahead and do a combined surgery. Okay. So now what I have realized is that a lot of patients, actually, if you do a trabeculectomy, I have to make them stay for at least 10 days, at least near our hospital. They are coming from out of Delhi. And a lot of people don't want to do that. So if the patient is controlled on medication and you feel that it will not get out of control by doing only a cataract, because many a times cataract actually can help lower reduce, then we can go with that. But like you said, if it is an uncontrolled on medication, then you don't have a choice. Then you have to do a combined surgery. But then combined surgery requires greater follow-up, and it has got less success than either a trab or a cataract alone. So if the cataract is not much, we may just end up doing a trabeculectomy. and do the cataract later. But if both are adequately there, there is 6/12 or 6/9 vision with an adequate cataract, and especially in angle closures, we would go more towards doing a combined surgery.
Monetary also it helps, na sir. Combined किया तो दो बार आना पड़ता नहीं है. Everything I think we keep it in mind. That is a very big issue nowadays. People don't turn up for follow-up and compliance. Yes, Purvi and Vinay and Vidya on this. Before we take the audience question.
So I agree with Dr. Harsh, and there would be 3 situations for just primary open angle glaucoma. There would be a few patients where I would only do trabeculectomy if the because that's the only way you'll be able to retain the sight actually. And the second would be, doing both surgeries together where both are indicated. And the third would be, as Dr. Harsh pointed out, that, the medical management is very good, the intraocular pressure is under control. You may just do a cataract surgery because doing a cataract surgery is really a much better thing for the patient, rather than doing a combined surgery. And if needed later on, he may go for trabeculectomy.
Okay.
Were you able to hear?
Yeah.
Okay.
With Purvi?
Yeah, very much the same as three separate set of scenarios. So you have to decide according to that. And only thing I would like to, just for the sake of the audience, talking of cataract extraction, not clear lens extraction.
Correct.
That needs to be kept in mind.
Correct. Yes, Vidya, anything to add?
Yes.
Otherwise, you can take the audience
Same
question.
thing, sir. Same thing. Everything has been said.
Same.
Only thing is the scenario where there is a cataract as well as a glaucoma, which would need a surgery. It is usually in the elderly patients. So in those patients, I would prefer a combined surgery. The lens is clear and there is severe glaucoma who needs a trabeculectomy alone. Those are usually younger patients in the elderly groups. I mean, above 60 or so. Usually when both the diseases are together, I would prefer a combined surgery.
Take the audience question now.
Yeah.
There's a question from Desai Eye Hospital. When can we decide to operate the patients who are already on medications?
Okay, so the question is, when do you want to operate? The first thing is that the patient is not controlled on all the medications which you can comfortably give to the patient without him having side effects. Number 2, the patient says, I'm fed up. My job is going to go if I keep putting medications. So I cannot put the medications, please operate me. The third thing, he's having allergies to the medications. And sometimes, even despite medications, the things are falling down and we feel that possibly he is not putting the medications or we are not up to the mark. Then we have to operate, or which comes to the same thing as that the patient actually is not able to afford or is not compliant.
Any other take by the rest of the panelists? Please put in their views. Vinay?
No, nothing to say.
Same.
Yeah.
I think
Yes,
we have
Vidya,
covered-
any more questions? Bol.
No, sir. We have almost covered everything.
Yeah, I think we have covered exhaustively.
Exhaustively,
A big thank you to all of you. I think we have come to the conclusion of the webinar, sir. Dr. Harsh Kumar, sir, very nice. They covered as we have just. So the moment you finish the talk, I said almost like a book. They have covered it very nicely, and the discussion has added that was the icing on the cake, with all the people putting valuable inputs into the whole of the webinar and this topic. And it's going to be really noteworthy once we come out with the booklet on this. It's going to be a big help to the general ophthalmologists at large, whether it is in Maharashtra or anywhere in India. So once again, my side, I would thank Dr. Harsh Kumar, sir, as a speaker, Dr. Vinnie Nangia and Dr. Purvi Bhagat to cover as being part of the panelists. And at one go, they really agreed. I just called up once everybody and they readily agreed to be part of this webinar. Thank you very much. And of course, Vidya doing the fantastic moderation on this. And we have the input people. They wanted to show a quick video before Dr. Rajesh Joshi takes over for the Thanksgiving. So Anmol and Ashwin, are you there? We take a screenshot first. gallery view screenshot, show your video, and then the Thanksgiving before we conclude.
So, sir, first screen.
Yeah, everybody put your video on, please. So we have a nostalgic screenshot for us. Yes, Vinay, your smile is very good. Yeah.
You
Go
can
ahead.
see me? Okay, good.
अच्छा दिख रहा है. मस्त.
Thank you, everyone. Thank you, Harsh Kumar, sir. Thank you, Nangia, sir. Thank you, ma'am,
Thank you.
for this wonderful webinar, wonderful discussion. Definitely
Yeah.
very useful to the audience. And there were
Yes.
several postgraduate students and fellows also attending this program. So they would have definitely, benefited a lot by this
Yes,
webinar.
yes, definitely.
A lot. Yeah. Thank you,
Ashwin,
everyone.
Anmol, would you like to show the video quickly? Are you loaded with that or we? The Endure people are always there as a good backup. They have a technical team, see that it works seamlessly. Thanks, Endure people also. And a big thank you to all of you. Over to you, Rajesh, for a vote of thanks.
Yeah. On behalf of MOS, I thank Dr. Harsh Kumar sir for highlighting on various aspects of open angle glaucoma practice. Your talk was to the point and useful to all the postgraduates, fellows, and general practitioners. Your tips for managing glaucoma will be beneficial in day-to-day practice. Thank you, sir, for sparing your valuable time. Thank you, Dr. Vinnie Nangia, sir, Dr. Bhagat, madam, for agreeing to be panelist and highlighting on various aspects of glaucoma. Thank you, Dr. Vidya, madam, for conducting the session so well. I'm also thankful to all those who have joined on virtual platform for today's webinar. Thanks to Entor for the technical support. Thank you all and good night.
Thank you.
Thanks a lot, everybody. Once more.
Thank you, Vignesh ji.
Right.
Bye-bye.
Yeah, we'll be having more on
See you.
glaucoma. It's a series which is going on. So we'll be in touch with you, sir, and
Good night.
everybody. Thanks a lot. Good night, sir.
Thank you. Thank you very much, everyone, and good night.
Thank
Good
you.
night. Vidya, thanks. Very nicely conducted.
Thank you, sir. Thank you, sir. Thank you.
We'll now see how
Very
many
well.
people have joined to through the Facebook or WhatsApp. I mean, YouTube and the webcast. Ashwin, Anmol, please put it on the group and see
Yes,
to it
doctor.
that we get
As
recording
I
of
receive it
every
from the
webinar, huh?
IT team, I'll put.
Yeah.
I'll put in the group.
Is it Ashwin who's speaking?
Ashwin.
हाँ अश्विन अरे परसों का भी